एनेस्थेसिया प्लान निर्माण गर्न सुझाए अनुरूप हाम्रो देशको सामर्थ्य सुहाउँदो एनसोप तयार पार्नको लागि विभिन्न सरकारवाला निकायहरूलाई ओरिएन्ट गर्न आयोजना गरिएको 4 दिने ओरिएन्टेसन प्रोग्रामको आज पहिलो दिन र यहाँ पहिलो दिनमा उपस्थित हुनुभएका सम्पूर्ण आदरणीय महानुभावहरू तथा जुमको माध्यमबाट हामीसँग प्रत्यक्ष जोडिनुभएका विभिन्न स्वदेशी तथा विदेशी डेलिगेट्सहरूलाई हार्दिक स्वागत अभिवादन टक्राउँदछु। म सन्तोष सुवेदी, मेडिकल टेक्नोलोजिस्ट, गुणस्तर मापन तथा नियमन महाशाखा। कार्यक्रमको औपचारिक सुरुवात म आसन ग्रहणबाट गर्न चाहन्छु र आसन ग्रहणको क्रममा यस कार्यक्रमको अध्यक्षता ग्रहण गर्दै अध्यक्षको आसन ग्रहण गरिदिनु हुनको लागि म स्वास्थ्य तथा जनसङ्ख्या मन्त्रालय गुणस्तर मापन तथा नियमन महाशाखाका प्रमुख डाक्टर मदन कुमार उपाध्यायज्यूलाई व्यासमा आमन्त्रित गर्दछु। यसै गरी हाम्रो कार्यक्रमको प्रमुख अतिथिको रूपमा हामीले स्वास्थ्य सेवा विभागका महानिर्देशक श्रीमान डाक्टर दिपेन्द्र रमण सिंहज्यूलाई आमन्त्रण गरेका छौँ र उहाँ आउँदै हुनुहुन्छ। उहाँको आसन ग्रहण हामी केही समयपछि गर्नेछौँ। त्यससँगै आसन ग्रहणकै कार्यक्रमलाई निरन्तरता दिन म चाहन्छु र आसन ग्रहणको लागि म आयुर्वेद तथा वैकल्पिक चिकित्सा विभागका महानिर्देशक डाक्टर वासुदेव उपाध्यायज्यूलाई अतिथिको आसन ग्रहण गरिदिनु हुन हार्दिक अनुरोध गर्दछु। यसै गरी म आसन ग्रहणकै क्रममा नेपाल मेडिकल काउन्सिलका अध्यक्ष डाक्टर भगवान कोइरालाज्यूलाई पनि अतिथिको आसन ग्रहण गरिदिनु हुन हार्दिक अनुरोध गर्दछु। यसका साथै हाम्रो कार्यक्रममा उपस्थित हुनुभएका सम्पूर्ण महाशाखा प्रमुखज्यूहरू, केन्द्र प्रमुखज्यूहरू, सहयोगी निकायका प्रतिनिधिहरू र त्यसै गरी विभिन्न एकाडेमियाबाट पाल्नुभएका प्रतिनिधिहरू र अन्य सबै यहाँ उपस्थित सम्पूर्ण महानुभावहरूलाई म यथास्थानमा आसन ग्रहण गरिदिनु हुन हार्दिक अनुरोध गर्दछु। Similarly, we have Dr. Zof Ibbotson from UNITAR and Dr. Rajesh Sambajirao Panda from WHO. Both of them are not present physically, and we are happy to get connected with them virtually. Likewise, we have Dr. Scott Corlew from Harvard, Dr. Kipak from Harvard, as well as Dr. Lumba Samath from IRD in our virtual platform. And we are happy that we have got them as a speaker in our program. र यसै गरी अन्य सम्पूर्ण महानुभावहरू पनि हामीसँग जुममा प्रत्यक्ष जोडिनु भएको छ र आजको कार्यक्रम जुम प्लस फिजिकल दुईटैको एउटा मिक्सअप कार्यक्रम हो। यसै गरी यहाँ उपस्थित हुनुभएका सम्पूर्ण महानुभावहरू तथा जुममा जोडिनुभएका सम्पूर्ण अतिथि वर्गहरूलाई स्वागत गर्दै आफ्नो स्वागत मन्तव्य दिनुहुनको लागि म स्वास्थ्य तथा जनसङ्ख्या मन्त्रालय गुणस्तर मापन तथा नियमन महाशाखाका प्रमुख डाक्टर मदन कुमार उपाध्यायज्यूलाई हार्दिक अनुरोध गर्दछु।
धन्यवाद सन्तोषजी। गुड इभिनिङ। यस एनसोप 4 दिने एनसोप वेबिनार का हाम्रा चिफ गेस्ट डाक्टर दिपेन्द्र आउँदै हुनुहुन्छ। उहाँ लगायत डायसमा आसीन मेडिकल काउन्सिलका चेयरम्यान सर, डिपार्टमेन्ट अफ आयुर्वेदका डिजी डाक्टर वासुदेव सर, मन्त्रालय र विभागबाट पाल्नुभएका महाशाखा प्रमुखजीहरू, यस हलमा उपस्थित अग्रज र हाम्रो यो 4 दिनको प्रोग्राममा मोडरेटरको रूपमा उपस्थित हुनुभएका डाक्टर साहबहरू र भर्चुअली हामीसँग जोडिनुभएका हार्वर्डबाट हाम्रा मित्रहरू जुन हामी लामो समयदेखि सहकार्यमै छौँ र यो NSOAP को वर्कसप गर्नु अगाडि हामी एक किसिमको सबैसँग सहकार्य गर्नको लागि एउटा प्लेटफर्म निर्माणको क्रममा आज यहाँ उपस्थित भएका छौँ। हामी हाइब्रिड रूपमा यहाँ उपस्थित छौँ। हामी इन पर्सन यो हलमा उपस्थित छौँ भने धेरै साथीहरू प्रदेशबाट र विश्वका धेरै ठाउँहरूबाट भर्चुअली पनि हामीसँग कनेक्टेड हुनुहुन्छ। म सम्पूर्ण यो कार्यक्रमलाई माया गरेर जोडिनु भएका सम्पूर्ण अग्रज र अतिथिज्यूहरूलाई धन्यवाद दिन चाहन्छु र स्वास्थ्य जनसङ्ख्या मन्त्रालयको यो एउटा महत्त्वपूर्ण कार्यक्रममा यहाँहरूको इनपुट एकदमै चाहिएको र हामी अगाडि बढ्नको लागि यहाँहरूको सहकार्यले एउटा पथ प्रदर्शकको भूमिका निर्वाह गर्नेछ भन्ने आशा गर्दै यो छोटो समयमा यहाँहरूलाई हामीले जुन निमन्त्रणा गर्यौं त्यो निमन्त्रणा स्वीकार गरेर यहाँहरू यहाँ उपस्थित भइदिनु भयो। म सम्पूर्ण साथीहरूलाई धन्यवाद दिँदै यो 4 दिनकै कार्यक्रममा यहाँहरूलाई स्वागत गर्न चाहन्छु र यो भर्चुअली र इन पर्सन दुईटै हुने हुनाले यहाँहरूको इच्छा अनुसार हामीसँग जोडिनुहुन्छ भन्ने पनि आशा गर्दै यो कार्यक्रममा पुनः स्वागत गर्दै अहिले बिदा हुन्छु। धन्यवाद।
धन्यवाद Dr. Modan. Now I request Dr. Zoe Evertson from UNITAR for keynote address. And Dr. Evertson is Senior Health Advisor and Executive Lead of Global Surgery Foundation. Dr. Evertson, now you can proceed ahead.
Well, thank you very much, and namaskar. It's wonderful to be able to join you. Can you all hear me well enough? Everyone give a little wave in the audience if you can hear me. Excellent, excellent. Well, greetings from Geneva, Switzerland. It's wonderful to be able to be joining you virtually. And on behalf of the United Nations Institute for Training and Research and the Global Surgery Foundation, we are very honored to be with you in this special event. As we know, surgery is one of the foundations of healthcare. And as countries like Nepal make a commitment to universal health coverage and to the SDGs, we know that surgical care, safe surgery and safe anesthesia obstetric care is an integral part of making that possible. Without having surgical care integrated, well integrated into health plans, countries will have great difficulty achieving the SDGs and universal health coverage. So I really want to commend Nepal and the Ministry of Health and Population on their efforts to move this forward. And on our part at UNITAR and the Global Surgery Foundation, we are very pleased to partner with you and co-host this orientation workshop. And also very pleased to work alongside Harvard PGSSC and getting support from Nick Simon's Institute and also CEDA. Whenever we aim to achieve great things, we have to do it together, and partnerships like this are very, very important. So I just want to make that point that alone we will not be able to achieve it, but together I think that is makes it much more likely to achieve our goals in this way. Now, I don't want to take too much time in this short introduction, but I just want to say that as countries like Nepal start their process of developing a national surgical plan and then integrating this into the national health strategy and integrating it with primary care and the different levels of healthcare like secondary, district level, tertiary care, it's very important to keep all of the aspects in mind as we move forward. And the one that I want to touch on is the financing. Innovative financing is so important to making this possible. And so bringing the people to the table for the discussions at the very beginning of the plan development of the people, the ministries, the external donor partners, that will help the process of innovative financing will be very important. And some of the sessions tomorrow, the breakout groups will discuss that. And I'm very pleased to see how the Ministry of Health in Nepal is already taking those steps. From our part at UNITAR and the Global Surgery Foundation, we stand committed to support the capacity building in this way and look forward to seeing the development of the NSOAP in Nepal, and look forward to working with you on that development. So I'll end there and turn the floor back over to our Master of Ceremonies. I look forward to seeing how this workshop develops over the next several days and the outcome in the next many months to come. Thank you very much, and namaste.
Thank you, Dr. Iverson. हामीमाझ औषधि व्यवस्था विभागका महानिर्देशक श्रीमान भरत भट्टराईज्यू आइपुग्नु भएको छ र उहाँलाई पनि म अतिथिको आसन ग्रहण गरिदिनु हुनको लागि ड्यासमा आमन्त्रित गर्दछु। र कीनोट्सकै कार्यक्रमलाई निरन्तरता दिँदै now I'd like to request Dr. Rajesh Sambajirao Pandav for your keynotes, and Dr. Pandav is a WHO representative to Nepal. Dr. Pandav, the floor is yours.
Thank you very much. Can you hear me clearly? You can raise your hand as the previous speaker said. Can you hear me? Thank you. I just want to confirm whether you can hear me. If you can raise your hands in the audience. In the room, are you able to hear me?
There is slight echo.
Is it better now?
Yeah, it's fine.
So thank you. So the Chief Guest Director General of Health Services, Dr. Dipendra Raman Singh, Dr. Madan Kumar Upadhyay, Dr. Bhagwan Korela, Dr. Vasudev Upadhyay, and Dr. Juak. Namaste. It's a pleasure to be at this on this webinar series, and thank you very much for this invitation. Clinical conditions requiring surgical, obstetric, and anesthesia services amount to 30% of the global disease burden. Yet, over 70% of the world's population cannot access safe, timely, and affordable surgical, obstetric, and anesthesia services when they need it. The human and economic losses due to the lack of safe surgery and anesthesia are too large to ignore. More than 70% of the world's population lacks access to surgical, obstetric, and anesthesia care, and 50% risk financial catastrophe from surgery. The 68th World Health Assembly in 2015 passed a resolution to strengthen emergency and essential surgical and anesthesia services as a component of universal health coverage. This effort was directed at strengthening surgical systems in WHO member states and realizing the United Nations Sustainable Development Goals. The resolution is a landmark resolution for surgical prioritization, which emphasizes that a significant portion of the global burden of disease can be successfully treated with surgical intervention, and specifically notes the beneficial effect of surgery on morbidity and mortality rates due to obstructed labor, cancer, road traffic accidents, and violence, all of which disproportionately affect low and middle income countries. The resolution 68.15 identifies five key surgical areas of focus: surgical and anesthesia workforce, information management, service delivery, essential medicines, and advocacy and resource development. Establishment of an adequate surgical and anesthesia workforce in low and middle income countries requires not only an increase in workforce volume, but also an enhancement of training programs. Increase efforts by credentialing bodies and possible support by mid-level providers. Most low-income and middle-income countries, including Nepal, have been facing a rising burden of non-communicable diseases, traumatic road traffic accident injuries, and other chronic conditions which require surgical intervention over the course of a patient's lifetime. However, prioritizing surgical services are often neglected in the mainstream discussions of global public health, and patients from remote villages and marginalized social groups continue facing significant hurdles when attempting to access surgical care. Universal health coverage and other health-related SDGs won't be attainable without ensuring that safe and affordable emergency and essential surgical, obstetric, and anesthesia services are available to all the people. Surgery is a complex intervention and requires a functioning health system, which in turn requires strategic planning. Development of a national strategy to improve surgical care while simultaneously strengthening appropriate infrastructure, a well-trained and well-distributed workforce, efficient service delivery, integrated information management, quality assurance, and adequate financing and governance in low and middle-income countries is an innovative approach to improve surgical care. The National Surgical Obstetric and Anaesthesia Plan identifies the current gaps in healthcare, prioritizes solutions, and provides an implementation framework which is specific and time-bound, annually prioritized with costed activities to reach each goal, and a robust monitoring and evaluation plan and a projected cost. The NSOAP establishes a unified vision for strengthening of surgical systems and the coordination of efforts required to achieve this. This webinar series, under the leadership of Ministry of Health and Population and support from UNITAR, should lay the foundation for developing the Nepal NSOAP and strengthening country capacity in delivering safe and affordable emergency and essential surgical, obstetric, and anesthesia services, and thereby have a significant impact on key targets of Sustainable Development Goals 2030. The event, as I understand, convenes advocates and actors from various partners, stakeholders, government, private sector, professional societies, academia, and donor agencies for learning and initiate the planning and establishment of a commitment for Nepal SOAP. Thank you for inviting. I wish the webinar series to be a success and commit to WHO support on these ongoing initiatives. Thank you and namaste.
Thank you, Dr. Pandav. अब म नेपाल मेडिकल काउन्सिलका अध्यक्ष डाक्टर भगवान कोइरालाज्यूलाई आफ्नो कीनोट एक्सप्रेसनको लागि हार्दिक अनुरोध गर्दछु।
Namaste and good evening everybody here, and good morning in Boston and good afternoon in Geneva. It's been a pleasure being able to participate in this very important meeting of orientation webinar series on developing Nepal NSOAP. Myself being a surgeon, and my colleagues, a lot of surgeons and clinicians are here. We have been long feeling that we are far from developing a robust health system which could tackle all the surgical clinical problems in Nepal, let alone the surgical issues. We know there are millions of patients who suffer with multiple surgical problems, including essential and emergencies, and they need to be tackled. What happens when they are not dealt with in time is they live with disabilities and pain and suffering, and that affects our economy and the growth negatively, and we all knew this. And in fact, last 2 decades or so, Nepal has gone pretty far in developing a lot of, fragmented programs in developing essential and comprehensive obstetric care and developing human resource. And in last few years has been very radical change in the way we produce specialist doctors and the way we deploy them in different facilities of Nepal. I think there have been significant progress in developing some of the surgical facilities in Nepal. But what has not been done yet, and I am happy to be part of this process, is how do we bring every initiative together, develop into a national plan so that every bit and piece is put together, all the dots are connected. We find the gaps. We have all the information, what is needed exactly in terms of serving our own people. What is that minimum standard that we can call it a universal health coverage for Nepal? So I think this, with the leadership of Ministry of Health, this is a significant step. And of course, we all will be part of this. And I thank the ministry for taking this lead and this had to happen. And with the partnership from UNITAR, the Harvard PGSSC, and all the team involved, and our external advisors and experts from other international community, like the experience from Pakistan, how they developed in the past, Lubna Samad and others. So I would like to thank everybody who has been involved in the preparation of this plan development process for Nepal for the last several months. That of course includes our, the key partner in Nepal, the NSI, and the team leader being Anil Shrestha and everybody else. Thank you, everybody. I like to thank the Harvard Group, Key Park, and Scott Corlew and others. Like to thank Jeff Ibbotson, of course. You've been there, always, and trying to put everybody together. And Lubna for being with us in this process. So, of course, I would like to thank our Ministry of Health as our leader in this whole process. Hopefully, with the work that we're going to do over the next 4 days, we'll come up with something robust to advise to the Ministry of Health. How should we move forward in planning and hopefully in implementing this, national program over the next several years to decades. And I really feel humbled and honored to be part of this, and thank you for inviting me to this project. Thank you, everybody.
धन्यवाद डाक्टर साहब। म कीनोट एक्सप्रेसनकै सिलसिलामा छु र यसपछि म औषधि व्यवस्था विभागका महानिर्देशक श्रीमान भरत भट्टराईज्यूलाई कीनोट एक्सप्रेसनको लागि मञ्चमा आमन्त्रित गर्दछु।
Yeah, distinguished guest from Department of Drug Administration. I wish all the best for this webinar. Though I am not much more oriented regarding the topic, I would like to say, as Dr. Bhagavan Karela has said already, and other people has said here regarding the surgical care. Since we have to achieve the universal health coverage, achieve the goals for SDG, in our country like Nepal, LMIC countries like Nepal, we have many things to go forward regarding the surgical care on behalf of the medicine and other health technological products also. Our DDA, Department of Drug Administration, is regulating and providing the affordable medicines here, whatever is needed regarding the surgical care. Also, we have got the minimum service standards also. We have got the protocols also. We are going for that also. And standard treatment protocols are there. So, a lot of interventions are required to move further, to achieve the equity, so as to achieve the universal health coverage. And I wish on behalf of Department of Drug Administration, we are here to coordinate, communicate, and collaborate in each sector that is needed in the future. Thank you so much, and all the best.
धन्यवाद भरत सर। अब म कीनोट एक्सप्रेसनको लागि आयुर्वेद तथा वैकल्पिक चिकित्सा विभागका महानिर्देशक श्रीमान डाक्टर वासुदेव उपाध्यायज्यूलाई आमन्त्रित गर्दछु।
धन्यवाद सर। यस 4 दिनको वेबिनारको उद्घाटन सत्रका अध्यक्षज्यू, नेपाल मेडिकल काउन्सिलका अध्यक्षज्यू डाक्टर भगवान कोइरालाज्यू, महानिर्देशक औषधि व्यवस्था विभाग र सम्पूर्ण राष्ट्रिय र अन्तर्राष्ट्रिय विद्वद्वर्गहरूमा नमस्कार छ। यो वेबिनार ज्ञान भन्ने कुरा कहिल्यै पनि पुग्दैन। यस्ता वेबिनारले हाम्रो नेपाल जस्तो विकासोन्मुख देशमा रहेका जनशक्तिहरूलाई अझ बढीभन्दा बढी ज्ञान पाउन फाइदाजनक हुनेछ भन्ने आशा छ। हाम्रो अझै पनि दूर दराजमा सुरक्षित प्रसुति नभएर धेरै आमाहरूले ज्यान गुमाएको अवस्था हामीले देखिरहेका छौँ। सो अर्बन र सेमी अर्बन एरियामा त केही सर्जिकल प्रोसिजरबाट बच्चा जन्माएर बचाउन सकिएको अवस्था छ, तर यस्ता प्रविधिहरूबाट अझै पनि दुर्गम क्षेत्रमा हामीले आमाहरूको बच्चाको ज्यान जोगाउन सक्यो भने अझ पनि प्रभावकारी हुनेछ। र यस्ता 4 दिनको वेबिनारले हाम्रा उपलब्ध जनशक्तिहरू, अझै पनि मलाई लाग्छ यस्ता जनशक्तिहरू नेपालमा अत्यन्त कमी अवस्था छ। भविष्यमा यही जनशक्तिबाट पनि नयाँ नयाँ प्रविधिहरूको मार्फत यस्ता वेबिनारबाट नयाँ नयाँ नलेजहरू गेन गरेर यो प्रक्रिया मार्फत विभिन्न सर्जिकल प्रोसिड्युरहरू दूर दराजसम्म पनि पुर्याउन हामी सक्षम हुनेछौँ भन्ने आशा लिएको छु। हुन त विशुद्ध मेरो आयुर्वेद तथा वैकल्पिक चिकित्सा विभाग भए तापनि मन्त्रालयको एक कर्मचारीको नाताले सहभागीको हिसाबले मेरो सम्पूर्ण साथ रहनेछ र हाम्रो मूल उद्देश्य भनेको नेपालभरि दुर्गम सुगम सबै ठाउँमा चाहिँ व्यक्तिको ज्यान जोगाउनु हो, सुरक्षित मातृत्वको जोगाउनु हो। त्यसकारणले यस्ता सेमिनारले, यो वेबिनारले हामीलाई चाहिँ प्रभावकारी रूपमा फाइदाजनक हुनेछ भन्ने पनि अपेक्षा लिएको छु र यसको 4 दिनको सफलतापूर्वक सम्पन्नताको शुभकामना गर्न चाहन्छु। धन्यवाद।
धन्यवाद वासुदेव भट्ट साहब। पक्कै पनि यो 4 दिनको कार्यक्रम पश्चात एनसोप निर्माण गर्नको लागि हामी सम्पूर्ण सरकारवाला निकायहरू ओरिएन्ट हुनेछौँ। डाक्टर साहबको वेलकम, डाक्टर साहबको रिमार्क्स सँगै I like to begin the second session of this program, and I like to begin the second session of this program with the presentation from Dr. Scott Corlew. Dr. Scott Corlew is a lecturer from Harvard University. Dr. Corlew, you can proceed ahead.
Good afternoon, and thanks to everyone for being here. I applaud everyone for being here. I think that what we're going to do over the next few days is one of the most important things and one of the wisest things that the country of Nepal can do. My name is Scott Corlew. I'm from the program in Global Surgery and Social Change at Harvard. I'll just say that from my perspective as an outsider, I see the surgical community in Nepal as being one of the highest quality in the world, and absolutely one of the highest quality in the world among similar income level countries. The only issue with surgery in Nepal is there's not enough of it. And that's why we're all here in an effort to expand surgical care such that more people who need it can get it in a timely fashion. My assignment in this conference right now is to talk about the background, the framework for how plans for surgical care within the overall national health plan can be developed. And of course, that information comes largely from the Landsat Commission report on global surgery that came out a few years ago. Most of you are probably reasonably familiar with that report, but maybe not. And this will be a good review. As you know, the Landsat set up this commission several years ago. It did extensive research over a couple of years. It had 33 commissioners from all over the world. It published its report in 2015. That report it's only 50 pages long. It's freely available online. There's no paywall. It's like I said, it's 50 pages, has a lot of tables, a lot of charts. It's a very easy read. If you're not familiar with it, please do read it. It is supported by extensive papers that back it up that are also free without a paywall. So, we're not advancing the slides. I'm not sure why. There we go. Let's go back to 1980. Dr. Houghton Mahler was the Director General of the WHO then. And at that time, way back then, he made the statement that a healthcare plan that did not include surgical care really was not a healthcare plan. 40 years later, Dr. Tedros said essentially the same thing. Let's go further and talk about the role of the surgical development, the sustainable development goals. And none of these three goals are going to be met without surgical care. Poverty, obviously, without the ability to take care of trauma, take care of many disease processes, people aren't able to work and therefore rendered destitute. Good health and well-being is sort of a no-brainer. And again, decent work and economic health is key. Surgical development has to be there. I won't go through the specifics of this slide. I took it from Lars Hagender, but basically everyone in the room can see that all of these conditions require surgical care. And without it, the involved patient is going to be severely disabled or dead. And to put in cold economic terms, removed from the workforce. So even if all you cared about is the economics, surgical care is still important. Getting more specific, surgical sustainable development goal 3 with maternal mortality ratio, preventable deaths, road traffic accidents, universal coverage, and financial risk protection that we'll talk about more are critical. So let's get directly to the report from the Lancet Commission on Global Surgery. The vision of this commission, obviously, universal access, and these words were chosen carefully: to safe and affordable surgical and anesthesia care when needed. The care has to be safe, it has to be affordable. If it's not those two things, it's not surgical care. We as surgeons also know that without our anesthesia colleagues, there's no surgical care. We are totally helpless when faced with a person with a complex problem without an anesthesia colleague who can keep the patient alive and do all the necessary things to allow the operation to take place. Again, the Lancet Commission, the final report itself, and supported by all of the background publications, most of which are freely available. The actual publications that support the Lancet Commission report itself are all freely available without a paywall. So what does the Lancet Commission report have in it? And first of all, it has 5 key messages, and we won't go over those. It then has core indicators that we can use to assess, to look at what is available surgically, what it is, what are the shortcomings, what can be done about it. And then finally, this Lancet Commission report provided a framework for doing exactly what we're doing here for the next few days, and that is a plan to incorporate surgical care into the National Health Plan. So these 5 key messages. The first, 5 billion people around the world cannot access safe surgery. Remember that the global population is about 7.8 billion. So about 2/3 of people in the world can access surgery when needed. Let's talk about what it means to access surgery. And first, the patient has to know that they need an operation. And if they can't access that surgery in a timely fashion, they don't have access. Next, let's say that the patient can get to a facility in a timely fashion, but does the facility have the capacity to do what's needed? And if the facility can't do it, let's say hypothetically that the patient gets to a well-equipped hospital, but it's a hospital that because of personnel shortages only has an anesthesia person there 2 days a week. And this isn't one of those days. So again, lack of capacity is lack of access. And then finally, safety. If the procedure cannot be done safely, that too is not access. So it requires multiple levels of function within the system. And that brings up the concept of the 3 delays. We have the first delay, that of the patient seeking care. Don't bother reading the slide, it's the fine print. But the first delay, seeking care, the patient has to understand and decide that they need surgical care. Secondly, they've got to be able to reach that care. If they figure out they need an operation, but they live a 10-day walk from any facility, That's a problem. And next is the concept of receiving that care. Once they get to the facility itself has to be able to deliver. Again, if an anesthesia person is only present 2 days a week, that can be a problem. So key message number 2, 143 million more procedures. This number is a few years old. I'm sure it's much larger now. But the derivative number below here, that the poorest 1/3 of the world's population only receives 6% of all procedures, that's sort of an indicting statement for the rest of the world. And it's something that, again, here over the next few days here in Nepal, we are trying to solve or rectify this discrepancy, at least in this part of the world. So key message number 3, 81 million people face catastrophic expenditures. No one should have to choose between being destitute and being alive. And this 81 million, 33 million of them face these catastrophic expenditures from direct medical costs, user fees when they get to a facility, the actual costs of the drugs, the care, the equipment, and so forth. The 48 million are due to secondary costs, for example, transportation. Keep in mind that these numbers do not even include the number of people rendered destitute from opportunity costs, from the inability to be at work. If you're a farmer or a rickshaw driver and you have a broken femur, it's going to be a while before you're back at work. And maybe your family can pick up the slack, maybe your friends can pick up the slack, but that's a huge amount of lost income that really needs to be taken care of. So let's talk about financial risk protection. This slide basically is a push for risk pooling, which, in another way of putting that is a form of insurance schemes. Surgery is generally time critical. It's generally not something that can be planned for. It's expensive. By risk pooling, by everyone paying into the pool, no one pays a lot. Everyone benefits because when anyone needs services, it's paid for. It's not rocket science. Key message number 4, investing in surgery is affordable, saves lives, promotes economic growth. In other words, it is an investment that pays off. Let's talk a little more about that. The Landsat Commission, specifically on this topic, looked at 88 low and lower middle income countries, went by the number 5,000 procedures per 100,000 population, and we'll talk a little bit more about that in a little bit, in over 15 years. And their modeling came up with the number $350 billion could be invested to provide this in these 88 countries. 350 billion is a lot of money. But when one looks at for example, and not to pick on anybody, but when one looks at the expenditure on military in the United States and in China, 350 billion all of a sudden is not quite as much money. Let's look further. What does $350 billion get us? It gets us preventing $12.3 trillion in GDP losses. That is, invest this $350 billion, you get $12.3 trillion back simply by keeping people at work, keeping people alive, and so forth. My little $7.3 billion for Nepal is, again, it's based on older numbers, and it's using 2010 dollars, so that I'm sure this number is greater now. If we can get the plan and get the funding and expand this care in Nepal over the next 10 to 15 years, this is a very conservative estimate of what it would add to the GDP. So key message number 5 from the Landsat Commission report is that surgery is indeed a critical part, a necessary part of healthcare in general. Again, 1/3 of the global burden of disease being surgical. If a plan does not address 1/3 of the healthcare issues, it's not a health plan. So let's talk more specifically about NSOAPs, National Surgical Obstetric and Anaesthesia Plans. And don't hold us to this name. These plans can be called anything. They can be called National Surgical Obstetric Anesthesia and Trauma Plans. They can have the word nursing in there. They can be called frameworks. But the bottom line is these are plans to incorporate overall surgical care into a national health plan. And what comprises these plans? We have these 6 pillars over here. First, let's talk about infrastructure briefly. We're talking hospital capacity, we're talking equipment, we're talking supplies, we're talking surgical instruments. But we're also talking about things like transportation. The best hospital in the world is of no use if no one can get to it. Next, let's talk about workforce. We must have not just the surgeons, but the nursing care. We've got to have appropriate high quality preoperative nursing, operating room nursing, post-operative nursing. We've got to have anesthesia care, again, of high quality that can manage complex issues. We obviously have to have the obstetricians, et cetera, et cetera, et cetera. But the workforce also means those who support healthcare. You know, the hospital housekeeping crew always comes to mind. So workforce also is a comprehensive concept. Let's talk about service delivery. Once we have all of those things, we got to be able to produce the operations. We'll talk more about that with the 5,000 operations for 100,000 population concept. Then the financing. No, this stuff isn't free, but again, it must be financed, and that includes at the patient level for the financial risk protection, but it also includes having the financing in the budget, in the National Health Plan budget to accomplish all these things. I think the number one issue that has kept surgery out of health plans over the past 40 years is the fact that there are upfront costs to surgical care that are recovered many times over, but it takes a few years. You've got to develop the surgeons, develop the anesthesia, develop the hospitals and so forth, and they don't pay for themselves within the current fiscal year. It takes how many years to develop a surgeon? We've all been there. And once that surgeon is developed, is trained and working, the financial return on that comes back, but it doesn't come back immediately. Information management, let's talk about that. If we don't keep up with what we do, we don't really know where we're doing well and where we're not. We don't know what to focus on to improve the overall system. So we've got to keep the records as we go. And finally, governance. Again, not to pick on anybody, but why does the United States have such a marginal overall health system? Because a large part of our population doesn't believe in the proper governance to develop it. So these core indicators, let's talk about these first. This 2-hour access comes about from the OB literature, but I think the OBs would say that the number probably should be 30 minutes to an hour. But it's an estimate. The SAO workforce, and by SAO, we're talking surgeons, obstetricians, and anesthesiologists. And what the Landsat Commission found was a bare minimum is 20 of these practitioners per 100,000 of the population. Surgical volume, again, the Landsat Commission found through its research with surgical care around the world that 5,000 cases per 100,000 population is probably a bare minimum for necessary care. Perioperative mortality, and we'll talk a bit more about that in a minute. The indicator here isn't a number of what the perioperative mortality should be, but is that everyone should be tracking it. We should be keeping up with it. We'll talk more about why that's true. And the last two talking about expenditure on the part of the patient. So these are rough numbers that I put together for Nepal. 2.9 per 100,000 in the workforce. Again, I think it's a very high quality surgical workforce, but it needs far more. Next, the procedures, 450 per 100,000, far short of the 5,000 per 100,000. That is really a minimum. And then catastrophic expense, Nepal has about 1/4 of its population with adequate financial risk protection. The workforce, I put this slide in just to show where this number came from. And again, these are estimates, but over here on the y-axis, we have life expectancy at birth. On the x-axis, we have specialist workers. This blue line right here is 20 per 100,000. And the point is, less than 20, as the number of workers goes up, the life expectancy goes up dramatically. But once you get to 20, there is an inflection point here, where above 20, you get a little bit of increased life expectancy, but not a ton. Up to 40, there is still some increase, but above 40, the line really almost levels out. So between 20 and 40 SAOs, if you will, surgeons, anesthesiologists, and obstetricians per 100,000 is an optimal, seems to be an optimal number. This is a map that Blake Al-Khair put together a few years ago. It may be a few years old, but I don't think is significantly out of date. The point being that in low-income countries, there are about 0.7 practitioners per 100,000. In high-income countries, almost 60. We're here to work on that inequity here in Nepal. So let's talk a little bit more about perioperative mortality rate. The point being that what it actually means is very different in different environments. Again, not to pick on anybody, but at Brigham and Women's Hospital in Boston, most of the time the patient should get to the hospital in a timely fashion. The hospital is generally able to deliver whatever is needed. They've got a ton of the best doctors in the world. No matter how sick the patient is, they've got the ability to manage them postoperatively. So basically, the perioperative mortality rate at that hospital really should be mostly a reflection of severity of disease. Some people are going to die from their disease, and all of us doctors in the world aren't going to help that. But let's look at a rural small hospital, and again, let's pick on somebody and say, let's say out in rural Western Nepal. If the patient with appendicitis doesn't get there for 5 days, and then the hospital doesn't have anesthesia personnel immediately available, and doesn't have a lot of postoperative care capacity, ICU if necessary, and so forth, then there is a real problem with the mortality. That patient may well not survive, and that has nothing to do with quality of care, and frankly, nothing to do with the severity of disease. But rather it's a function of the overall healthcare system. And again, that's what we're here to try to solve over the next few days. So I have do not read across this because this is fine print. Don't try to read the slide. But the point is that on the left side, we have the indicator, those 6 indicators we just talked about. In the middle, we have an expanded definition. And over here on the right, we have a set target. And the point is that it's very easy to put this together in a little matrix like this and follow it. Set goals, make a plan to try to meet this. And so these indicators and these targets are actually quite straightforward. So to wrap up, what we're talking about here is equitable access to quality care. Again, the quality part I think we already have here. What we're looking to do is expand access so that everyone, whether they are in rural Western Nepal or in Kathmandu, have access to that care. The financial risk protection part, so that, again, no one has to choose between being destitute and being alive. And finally, measurement and accountability, keeping up with things so we know what we're doing well, and what we could be doing better. And always keep in mind that from the Ministry of Health point of view, 1/3 of health problems are surgical related. And that's why the ministry is so well represented in this conference today. We're all trying to achieve this goal. So thank you very much. Again, I appreciate and applaud everyone being here. I do think this is one of the most wise and valuable gatherings that everyone could be having. So thank you very much, and let's have a good 3 or 4 days.
Thank you, Dr. Scott Corlew. And I express my apology for not telling his title of the presentation. हामी माझ Next. Okay, let's continue presentation. Now I'd like to call upon Dr. Madan Kumar Upadhyay. Dr. Upadhyay is a Chief of Quality Standard and Regulatory Division, Ministry of Health and Population, and his title of presentation is Current Status of Surgical Care in Nepal.
Thank you, Santosh. Thank you, Scott, for your wonderful presentation. It made me easier for my presentations. You just gave a brief and background and platform for me. So I may speak only regarding the status of Nepal, the current status of surgical care in Nepal. Slide, please. So these are my outline of presentations. Next slide, please. So as Scott already mentioned, the rationale of NSOAP, as we know, there is the burden of disease is shifting towards, we have a double, or we can say we are facing triple burden of disease at present. And there are increased trend of disease, non-communicable disease, there are road traffic accidents, which are rising every day. So we can face lots of problems, lots of cases. There are approximately 30% of burden of disease due to surgical conditions worldwide. So these all thing had been stated in Scott's slides, and these are all repetitions in my slides. These are all same worldwide. And there is the huge out-of-pocket expenditure. There, as we know, it is a catastrophic. The cost of surgery is high. This is compared to other part of the country also, and we low-income country also face the same. And the SS, which Scott's slides expressed very nicely regarding the SS. So we have also the very low SS in surgeries. Next slide, please. So we are very lucky. Our Constitution of Nepal has established basic health care as a fundamental right of its citizens. So we have our law, our Constitution stating which all should get basic health services. Next slide, please. And there are lots of policies, plans, and lots of our signatory agendas here, which states the basic health services. There are free basic health services. National health policy also states free basic health services for all insured, and there are specialized services should be accessible throughout health insurance service. Basic emergency health services should be insured for all citizens. So these are all in our policies. Next slide, please. So there is National Health Sector Strategy Implementation Plan also states that which improve human resource ability to all levels with focus in rural retention and enrollment. It also says regarding rural and urban also. So as we know, we have less access, less support in rural areas. So our strategy implementation plan also states it. It says improve medical and public education and competencies and improve access to health service. These all are in the strategy plan. Next slide, please. So our law also, our public health service regulation also states the ministry or provincial government shall be able to provide specialist services along with general surgery, anesthesia, orthopedics, and telemedicine also. The government of Nepal and provincial government of the local level also shall provide specialist services. So we have 3 tier of government. So in all level of government, there should be free services of basic health and specialist services should be provided in every level of hospitals. Next slide, please. So our 5th 5-year development plan also says the scholarship for study in different healths. So we are just talking about our 6 domain of in every domain there are some policies, plans and implementation done. So scholarship for study in different health sciences based on need. There is basic health service provided free of cost. Health insurance is there, and there is technology friendly data management is there for information management. There should be electronic reporting and recording. Next, please. So our budget speech this fiscal year, current fiscal year budget speech also states there should be 5, 10, 15 bed hospitals in every local level, in rural municipality also. There should be increased access in basic health service through telemedicine and mobile clinics, and provision of specialist services through satellite clinic. Next, please. So we have lots of policies, plans and implementation done in every aspect in 6 domains. So we had a lot of things. So we had started this NSOAP platform very early, but the formally NSOAP will be there after we will complete this 4 days webinar, and we will be again. So current efforts in 6 domains of surgical health system, as I stated. As we are all aware, and Scott, we saw the presentation in Scott also, there is service delivery is the first one, there is infrastructure, workforce, financing, information management, governance. So we all are working on these 6 domains of surgical health system. Next, please. So regarding service delivery, as you know, the government began providing essential healthcare services, emergency as well as inpatient service, free of charge to destitute, poor, disabled, senior citizens, victims of gender violence and others in up to 25 bedded hospitals and primary healthcare centers. It's already began in 2006. Safe Motherhood program, which comprise of comprehensive emergency obstetric and neonatal care, which includes cesarean sections, anesthesia and blood transfusions, already started early as a Safe Motherhood program, which is the successful program. And the curative service support program is there with public-private partnerships with the modality to provide life-saving emergencies operations from primary and secondary A hospitals. As we had categorized our hospitals in the primary, secondary and tertiary level hospitals, we are providing curative service support program through PPP model. Next, please. So you can see in this slide, this is the minimum service standard has been enrolled, as it is a tool of quality, readiness of tool for quality. So to ensure readiness of quality service, there you can see there are a number of hospitals with MSS standards and average score. So this average score also ensure the readiness for providing the services. Next slide, please. So regarding infrastructure, we have developed standards in 2017. There is proposed 753 hospitals in rural municipality throughout Nepal. We have primary and secondary hospital in every district. There is functioning OT in 65 hospitals out of 90 primary and secondary A. There are oxygen plants. As this COVID pandemic, we got 42 oxygen PSA plant and 5 oxygen tank. And there are 16 storage blood banks and walking blood banks among primary and secondary hospitals. And there are 66 hospital pharmacy. Their own hospital pharmacy is there in primary and secondary hospitals. So regarding infrastructure, you can see the number of hospitals according to the province. In 7 provinces, we have 1,993 public and non-public hospitals. Next. So regarding workforce, as I stated, we started very long back in the scholarship program for all paramedics and medical students. So we had medical institutions in each province. There is bonded scholarship program of MBBS, MD, MS, DM, MCH, and with nursing faculty and paramedics faculty also. There are around 1,405 MD/MS graduates and 149 DMMCS graduate scholarship provided from 2072 till date. And there are lots of programs, scholarship programs for all health workers in government health institutions. So there are few training courses which support the workforce in surgical and anesthesia. There are anesthesia assistants, advanced SBA training, operation theater, technique management, primary trauma care, and essential critical care training. So we had prepared a few workforce regarding this, and you can see in the number, there are total 3,176 registered specialists in regarding this surgery, obstetric anesthesia, and there are 320 scholarship under scholarship program. Next, please. So you can see in number there are 1,072 scholarship graduates with the MD/MS program, and there are, as I stated earlier, it is 1,405 scholarship provided till date. So we had a lot of workforce ready to serve in rural area also. Next slide, please. So regarding financing, as you all know, basic health service is provided free of cost from government facilities, and where most of emergency care services are also covered. And we have social health security program running with lots of scheme. It is, as you know, to decrease the out-of-pocket expenditure, and it is implemented in 75 districts. Only 2 districts are being left, and 736 local levels has been covered out of 753. So it is family insurance scheme, and special package is there for geriatric age group. Next, please. And we also have improvised citizens service scheme. We have a scheme from 1 lakh to 4 lakh for renal disease, carcinoma, and there is for head injury, sickle cell anemia, Alzheimer's, Parkinson's, and spinal injuries, and heart problems. And I already stated there are government funded scholarship for all clinical and non-clinical subjects, MBBS to DMMCS, and there is support of EDPs to implement health sector strategies and policies. Next, please. So regarding information management, we have lots of platform. It is DHIS2 for regarding reporting and management system. It is ALMIS for logistic management. It is there is EWARS. It is just an example of surveillance response system. There are lots of others also. And there is information management unit for COVID best. So there is SIGAS for accounting. So lots of hospitals had initiated the electronic health recording. So we had lots of platform in information management. Next, please. So regarding governance, we had 3 tiers of government, as you know, central, provincial, and local. And the Constitution had already assigned management of basic health care services to the local level, and Local Development Operational Act is there for the government's local level, and there is a participatory bottom-up planning approach. So there, as you know, we had lots of preliminary work has been done. There are lots of things been done in bits and pieces, but we have to put in this systematic way. Next. So I just want to continue with the surgical status, as we had already known the status of all. So what is the surgical status of Nepal? The surgery in Nepal, as you know, there is national health system is more focused on preventive rather than promotive in a curative aspect. So it is in preventive and promotive since long, and public health interventions such as immunization, nutrition, and family planning was initiated very early. We are sorry that we had only started hospital-based focused review in recent years. It is very few years back we had started to review our hospital status, and lack of appropriate deployment mechanism of skilled health human resource is one of the hindrance we can say in surgery in Nepal, and surgical needs are not met due to lack of appropriate surgical pathways, and it is, I think, the same around the globe. Next slide, please. You can see there beyond cesarean section, as the Safe Motherhood program is very successful program in our country. Little attention had been given to other surgeries. So reporting of surgical volume is also limited. It may measure, it is reported as CS or major and minor surgeries. There is a lack of appropriate mechanism of collecting surgical data. So limited segregated surgical data is there. So it is, but we had lots of data there, but we have to explore it. Next, please. So surgery in Nepal, remote districts, there was a study done in 2016. It is only the symbolic which I want to present in front of you. There were only 39 hospitals in 25 remote districts were selected. And the main objective was to determine the surgical volumes and readiness in Nepal's remote districts. Compared to this with Landsat Commission's indicators and analyze characteristics of a functional district surgical team. So it was done in 2016. And there were some variables. So you can see surgical volume, the SS, human resource for surgery and facility for surgery. Next, please. So in this study, it was bellwether procedures was seen. Next, please. So the major findings of the study was 387 operations per 100,000 population against the Landsat target, which was 5,000 per 100,000. So you can see the number compared to globe. So access to bellwether procedures, there were certain percentages there, which is as compared to world, it may be minimum, but in some surgical procedures, it are very good enough. In cesarean section, it was 97%, laparotomy only 22%, and major operative orthopedics was 34.8%. This number, the performer wears MDGPs and advanced SBI, I think. So surgery can be done in the districts, but rates are very low. There are surgical MP districts and wide variations also. So we had some findings in 2016. Next slide, please. So there were 13 hospitals were performing cesarean sections and laparotomies, and the presence of MDGP was significantly associated with performing the bellwether procedure. So the main workforce behind this data are the GPs. Next slide, please. So you can see the number in a graph, and there you can see the highlighted one. These are the laparotomy done performed in different districts. Next slide, please. So major findings, it continued as the SOA specialist density is very low at our country. It is 0.4 per 100,000 against the Landsat target, which is 20. And generalist surgical team density is 3.1 per 100,000, 8 times higher than SAO density. So GSOA team based on MDGP are successful filling the gaps till date. So enabling environment is not adequate in many hospitals. Was the findings, and data tool can be used in this, and successful hospitals have motivated teams with managerial support. So these were the major findings of that study. Next, please. So there were few recommendations of this study. These are the MDGP led teams safely doing CS and other life-saving surgeries in a district hospital is a successful model. This model should be supported to increase bellwether, capable hospitals, skilled human resource and enabling environment of surgery must be urgently improved to the minimum standard, and monitoring of effective surgical coverage must be embedded in HMS using adapted surgical data tools and Landsat targets. So this is the overview of surgery, and there is I just talked about example of one study which was done in 2016. So I want to conclude my presentation saying this, and I want to thank you all, and I end up with my presentation. Thank you. And I want to welcome our Director General, Department of Health Services, as a chief guest in the dais. Please, sir.
धन्यवाद मदन डाक्टर साहब। र हामी माझ हाम्रो निमन्त्रणालाई स्वीकार गरेर हाम्रो कार्यक्रमको गरिमा बढाउनको लागि स्वास्थ्य सेवा विभागका महानिर्देशक डाक्टर दिपेन्द्र रमण सिंहजी आइसक्नु भएको छ र साथै आसन ग्रहण पनि गरिसक्नु भएको छ. Okay, now let's get back to the presentation, and the next presentation is from Dr. Key Park. Dr. Park is Director of Policy and Advocacy from Harvard Medical School, and his title of presentation is NSOAP Introduction, a Theoretical Framework. Okay, Dr. Park, you can proceed.
Good afternoon. My name is Keith Park. I am the Director of Policy and Advocacy with the Program in Global Surgery and Social Change at Harvard Medical School. I just wanted to thank the organizers, the main organizers of this webinar series, the Government of Nepal, the Ministry of Health and Population, as well as the UN Institute for Training and Research. This is an excellent series of webinars. And my talk today is to really tell a little bit about what an NSOAP is. As you will know by now, this series of webinar is called Nepal NSOAP Orientation. And you may be wondering, what are we talking about here? So that's my job, to explain what it is, how it fits into the overall process in strengthening surgical care in a given country, such as Nepal, what it is, and just as importantly, what it is not. So you've already heard a series of talks by previous speakers, specifically Dr. Scott Corlew's talk, where he explained how surgical care fits into the overall global health landscape, and more importantly, how it ties into the achievement of a number of sustainable development goal targets. And then you also heard about the current state of surgical care in Nepal. So let's go ahead and dive into what an NSOAP is. And I want to just zoom out a little bit and talk about how NSOAP fits into the overall global surgery narrative. So many of you know, in 2015 at the World Health Assembly, a resolution was passed unanimously calling for strengthening emergency and essential surgical care and anesthesia as a component of universal health coverage. And this really asked ministries of health to go back to their countries and develop strategic plans as the first step in strengthening surgical care. And I'm happy to report that over the last 5-6 years since the resolution passed, more than half the countries in the lower middle income category have initiated or in the process or even completed national surgical obstetric and anesthesia plans. And I think we've passed the tipping point, and more countries are coming online every day. And I just want to point out the importance of the regional blocks and the role they played in driving the sort of a political will to get this done. The Southern African Development Community, 16 countries, the health ministers came together and committed to developing national surgical plans as a first step towards strengthening surgical care in their region. In a similar fashion, the health ministers of the Southern Pacific community did the same thing, and they also drove the Western Pacific Regional Office of WHO into including surgical care. It's called safe and affordable surgical care as one of their top agenda items going forward. So these regional blocks are incredibly important, and thank you all for being part of the global surgery movement. And NSOAP is really the first tangible step that countries can take in initiating national level scaling of surgical care. It's really a strategic planning process. Of course, it needs to be implemented to ultimately benefit the patients who need surgical care, but it is the first step. And we're happy to report that more than half the countries in the LMIC categories are now involved with it. How do we do an NSOAP? It's a great question, and we actually have a great answer for that. the Harvard program in global surgery and social change. We actually wrote the manual on how to do this with input from a number of countries and experts. And this was a joint effort with the Global Surgery Foundation and UNITAR, and we're able to publish the manual. It's free of charge. The link is on the slide, www.globalsurgeryfoundation.org, NSOAP manual. Please download it. It's a fairly extensive document, but it has everything you really want to know about the NSOAP process. And a number of slides that are coming following this actually are taken right out of this particular manual. So what is the NSOAP process? It all starts with the Ministry of Health commitment. It needs a local champion and has to be driven by country champions. It is not an externally driven process. It's an internally motivated and driven process. So once you have the Ministry of Health initiating this process, the first step is to convene a multi-stakeholder engagement. You bring together everyone in the country that have interest in seeing surgical care improved. This is maternal health groups, injury groups, civil society groups, academics, clinicians, other health professionals, nurses, anesthesiologists, obstetricians, so on and so forth. Bring them together and go through a situational analysis. Where is this country currently at as far as surgical care? Fortunately for Nepal, this process actually has been finished with help from the Nick Simons Institute. They did a very, very thorough baselining process a couple of years ago. And this is, so you've already fulfilled some of the key components of the National Surgical Plan. Then the next step involves having a vision about where the country wants to go. What are the targets? What are the priorities? What are the visions, the priority setting exercise? And this is jointly derived. It's not a top-down process, but more of a consultative and a participatory process, especially when we have to hear from the patients groups, the civil society, because ultimately they're the ones that will be accessing these services. Then all this information, the situation analysis, the priority setting is now drafted into a document. And then there's a series of exercise to help determine how to measure progress as this particular plan is implemented. So monitoring and evaluation framework, as well as who would implement a complex health initiative such as a national surgical plan. I don't think that this can be managed through just one or two people. It needs to be a team of people who can, number one, finish the NSOAP process and deliver on the product. But then again, just as importantly, as they go to operationalize and finance these plans and see to its implementation and ultimately benefiting the patients. So there absolutely has to be an investment and a mechanism for governance and management of these plans. Then it has to be costed. How much will this cost? The ministries of finance will be very interested in knowing how much this will overall be, how much they have to prepare and how much they will need to get external assistance, so on and so forth. And then it has to go through a process of a legislative or approval at the policy level, initially at the Ministry of Public Health, and then most likely, and we recommend getting it through the National Assembly if it's possible, and then integrate it into the National Health Sector Plan and or Development Plan. And that way it's fully integrated and has the best probability of having it implemented. These plans can be developed, but can sit on the shelves for a long time without additional movement. And then, of course, the project has to be implemented. And there are three considerations as the projects are implemented. One is funding. These are very costly plans, hundreds of millions of dollars or even more. So the source of funding for the scale up, as well as the actual cost of provision of services once the surgical services are scaled up, these are considerations that need to be carefully vetted with the Ministry of Finance early on. And then data collection, all this, as these surgical services are scaled up, what are the metrics that will be used to measure progress in safety as well as service delivery? And data collection has to be beefed up. And as I mentioned earlier, governance and managerial capacity has to be beefed up. So I alluded to a little bit earlier on integration. I do think it's worthy of discussing it a little bit more in detail. So the NSOAP strategy has 6 building blocks. This is using the health systems building blocks model from the World Health Organization. There's a service delivery building block, infrastructure building block, workforce, information management, financing, and governance. And these are the 6 domains that the NSOAP is built upon. Now, you now have a product at the end, an NSOAP strategy. But as you all well know, as policymakers of the ministries, there are a number of strategic plans. And the question is, as you sit at the Ministries of Health, how does an NSOAP plan, the National Surgical Plan, integrate to, let's say, the NCD strategy or injury strategy? And this has to be, the idea of integrating these things must be done at the high levels of health ministry. That surgery is an intervention. It is not a condition, and it's cross-cutting. And so it lends itself to be integrated to all the other plans. For instance, maternal reduction of maternal mortality. Absolutely. Emergency obstetrics is a key component of reducing MMR. Injury reduction, cancer care, all those things. So the integration at the strategic planning level as well as service delivery level is very important. And this is a very important job for the ministry itself. And as I mentioned, these plans should be integrated at the National Health Strategic Plan level, and even maybe at the National Development Plan level. So this will ensure its execution and smooth integration and operationalization. So what NSOAP is? Really, the end is it's a strategic plan, a roadmap, if you will, to prevent things like the picture on the left, a bike path that goes into a guardrail. Without careful planning, you end up with dead ends or unintended consequences. Or on the picture on the right is actually an unplanned but built sort of randomly. It's a favela in Brazil, where it's houses on top of houses, and there's no urban planning. And you can imagine the complexities of trying to have sanitation and water and electricity in this kind of neighborhood. So what NSOAP is really a careful planning process to avoid these kinds of unintended consequences as you build up the health system. So it's just a blueprint, right? So and then it's actually a costed blueprint. So it's people know exactly what this is going to entail financially. And it's a sequential roadmap in how to scale up surgical care. So this is what NSOAP is. What NSOAP is not is a roadmap doesn't necessarily mean the building is built. A blueprint does not equate a built building. We actually have to drive the road. We actually have to use a blueprint to build a building. So an NSOAP is not synonymous with the actual action. It's just a plan. And this is the key. We have to be able to build it, be able to finance it, and ultimately be able to do things like training surgeons, and then ultimately make a difference at the individual level, at the patient level. In the picture on the lower right is a picture of a club foot. And we have to keep our eyes on the patients who need the surgery, who are not able to get surgery today. Those are the patients who we're doing this for. And ultimately, NSOAP is a first step, but it must be integrated and implemented so that these patients can get surgical care. So can NSOAP be modified? Absolutely. It is only a framework. It is designed to make sure that we think about all the components of a surgical subsystem in the health system, but it should be customized and contextualized by each country. In fact, the Western Pacific Regional Office, when the member states approached them and said, we want to prioritize surgical care, they developed a regional action framework for surgical care to give countries as much flexibility and leeway in developing their own pathway to strengthen the surgical care. And that's worked out really well. So it's really not a prescriptive plan. It's really a way to think about the system and making sure that certain parts are not neglected as you build up a system. Fiji has done it in their own personal way. Their stakeholder engagement was done, and I had the honor of attending it, and it was done in such a customized way because they have very unique needs. It's a number of islands that had to be served, and so each country has to contextualize it. Rwanda, they were able to achieve data collection from all the hospitals through a mandate from this Ministry of Health, is saying, please give us all this data within 30 days. And they complied, and they did the situational analysis very quickly. Nigeria actually added an extra letter to their plan. It's their National Surgical Anesthesia, Obstetrics, and Nursing Plan. I thought that was amazing. And they had included nursing into their overall national plan. And then I just mentioned Pakistan because Dr. Lubna Samad will be speaking right after me, and you'll be able to hear in more detail how Pakistan has been able to adopt and customize the planning process into their needs. So there are challenges in implementing national surgical anesthesia obstetric plans. One, as I mentioned, is the governance and managerial capacity. I would only mention that there is a program housed at the Aspen Institute called AMP Health, and they will actually provide and send managerial experts embedded at the ministry level to provide assistance. So if any countries are interested in people coming in with, let's say, consulting experience, managerial experience, this is a program that can help provide some of that capacity. And then, of course, implementing a surgical strengthening program sounds great, but at the district level, what does that mean? How do you actually scale up surgical care at district levels, health systems? I mentioned two organizations that we work with who are experts at implementation science, Ariadne Labs and Partners in Health. And once again, we have access to their expertise, and they can translate to assistance to ministries of health as well. So the last, the hurdle is financing. The Nigerian the National Surgical Plan is actually over $1 billion. And we don't know what Nepal's is going to cost. But I will tell you, we've been working hard and trying to get donors. These are overseas development assistance agencies like USAID. And we're working with the lawmakers in the US, for instance, because we're US based, and trying to get USAID to prioritize surgical care. And I would say that we've been successful in getting the Congress to recommend to USAID to strengthen surgical health capacity and assist ministries of health to develop and implement national surgical obstetrics, trauma, and anesthesia plans. It's exactly in line with what Nepal is doing. It is now a part of the language that USAID has been provided. And so now we should be able to match proposals for national surgical plans, implementation projects to USAID funding streams. We've also engaged with the World Bank Group, the Global Financing Facility, with support for going back 3 or 4 years, with Jim Kim when he was the president, and Dr. Pate when he was recently the World Bank the Health, Population, Nutrition, and Global Financing Facility director. They've been very supportive. And I would just add that Dr. Pate now has stepped down, and there's a new head of Global Financing Facility and Global Health, the Health and Nutrition and Population at World Bank, Juan Pablo Uribe. And he's actually a surgeon, is what I was told, which is really bodes well for us. And then you might know who the gentleman on the lower right is. That's Dr. Atul Gawande. He's actually was the executive director for Ariadne at Harvard. He's a surgeon, and he just has been named or nominated to head up global health for USAID. So I would only say that stars are lining up for us, and it's only there has never been a better time for countries to strengthen surgical care as it is today. So I just want to say thank you for your attention. We're delighted to be participating in this the NSOAP's orientation in Nepal. We've seen some tremendous progress, and we are here to support, and we look forward to cooperating with you further. Thank you very much.
Thank you, Dr. Park, for your nice presentation. Now, I call upon Dr. Lumna Samad for the next presentation. And Dr. Samad is pediatric surgeon and director at IRD Global. And the topic of presentation is NSOAP Developmental Process Model. Okay, Samad, you can go ahead.
Okay, that should be better. I'm unmuted now. Can you hear me clearly now? Yes. Great, thank you. Good evening and namaskar to everyone. Thank you so very much for inviting me to talk about our experience in Pakistan. Even as you start your work in Nepal, I find I have so much to learn from what your government and your surgical community is already doing. And I hope that this will be the beginning of a partnership between our countries. We're almost neighbors, and it's very useful to learn from what people in our own region are doing. Those solutions are the ones that work best given the local context. So I do hope my next few slides and the experience that we have gone through in Pakistan will be helpful for all our friends and colleagues in Nepal. So just to give a quick recap, Pakistan is a country of over 200 million people located in Asia. It is a large country with a big population. There are 4 provinces. This is specifically important for us because in 2008, many of our ministries were devolved, and therefore health, for example, is completely an autonomous subject for each province to implement. So while a number of our health policies are designed and defined at a national level with provincial input, eventually the implementation of these policies is the responsibility of provincial governments. This is helpful in that it gives provinces a lot more say in catering to the needs of their own people, but it also has its problems when provincial governments are often from a different political party than the center, and the tussle then for what gets implemented can become difficult. So again, as with many things, there are pros and cons to it. What's important to understand is for Pakistan and for a lot of our neighbors, the under 15 population is significant. So as a pediatric surgeon, I found this very important in the way we regarded national surgical planning, because with a fifth of your population in the under 15 age range, and this becomes bigger if we talk about the UNICEF demarcation of under 19 as the pediatric or children population, we're looking at a lot of conditions and a lot of surgical interventions that require people specially trained in meeting those needs. And that has to be catered to as we look through our implementation. Now, why did we need a national surgical plan? Obviously, in Pakistan, the estimates are that the number of deaths per 100,000 population due to conditions that have a primarily surgical solution exceed those of all the infectious diseases combined. Now, this is a big number, and it's not highlighted as much as we would like it to be. In contrast, we have major funding streams taking care of TB, AIDS, malaria, and other infectious diseases. But as Dr. Park mentioned earlier, very little funding is available to focus on surgical systems per se. What often happens then is that we start to look at surgery in our national health agenda as something that takes place in ORs, is a tertiary care issue, and needs to be dealt with somehow separately from the other global health or public health agendas that are important. I'm not saying the others are not important, but I think it is important for surgery to be perceived as an equal partner in that planning process at the national level. Our maternal mortality is high, and a lot of these deaths are attributable to absence of operative intervention as in where needed. So it's when and where needed, which is very important. We have an estimated annual deficit of anywhere between 10 to 17 million surgical procedures, and this is before COVID did its destruction. We now have backlogs of surgical care in all parts of the world. It's not restricted to LMICs, but obviously LMICs have been worse affected as always. We have an SAOA density, which is lower than the minimum target set up by the Landsat Commission. What is very important is not only are these resources less than the benchmarks, there is a hugely inequitable distribution of these resources, both human resources, financial resources, and the target of this maldistribution is the secondary level. The district headquarter hospitals, the taluka hospitals, as we call them in our part of the world, which are located within catchment populations in each district or area of the country. This is where we need the surgical workforce, the funding sources, the blood banks, the technicians, the nurses to be optimized, because this is where the bulk of our essential and emergency surgical procedures need to take place, closer to populations. And this is where the inequity is largest. And we'll talk a little bit about how we address this particular point when we designed our national surgical plan. So, as the NSOAP framework says, the stakeholder engagement is very important. And in our case, it was drawn out over a 2-year period where an initial contact by Dr. Safi Malik, representing the World Health, representing Pakistan at the World Health Assembly in 2016, came and gave a talk at the G4 Alliance meeting. It was an evening event where a number of us were available, had made ourselves available to participate in a global representation and discussion on how to get the importance of surgical care across to different governments. And Dr. Safi Malik, who is standing next to me, was there. And it's interesting to note that I was the only one of these 3 colleagues of mine who was working in Pakistan. Dr. Safi Malik is based in Islamabad. I was based in Karachi. Adil was based, Dr. Adil Haider was based in at the Harvard Medical School at that time, and Dr. Asad Latif on the other side was based at Johns Hopkins University. I'm very proud to tell you that both of them are currently working in Karachi in Pakistan. They returned back. And one of the reasons for the global surgery agenda coming to the forefront in Pakistan is because people all over the world, Pakistanis all over the world, understanding the importance of improving surgical care and the importance of having surgeons and anesthesiologists. Dean Heather is Dean at Aga Khan University right now and is a trauma surgeon. And Dr. Asad Latif is the chair of anesthesia there now and a practicing anesthesiologist. Both of them understood the importance and came back to help drive this agenda forward. So individuals and many, many colleagues across the country have helped take this agenda forward. We then had a regional meeting hosted in Dubai in March 2018. This was hosted by PGSSC and the Harvard Center for Global Health Delivery in Dubai, where a number of people from across Africa especially, and some parts of Asia came to discuss the importance of NSOAPs. And this was a way of getting government officials to tune into the importance of NSOAPs, of surgical plans, and take the message back to their countries. And finally, 2 years later in May 2018, again, we had Dr. Safi Malik representing the Pakistani delegation at the World Health Assembly in Geneva. And we have Dr. Corlew, Walt Johnson, who was representing WHO at that time, members of the World Federation of the Society of Anesthesiologists, and Dr. Park. So many of our international partners have continued to stand with us over years and bring this matter to the attention of governments. Soon after this meeting in May 2018 in Geneva, we were able to return to Pakistan and continue these discussions with our ministry with the strong support of our own ministry officials. We were able to get a letter of understanding signed between our ministry and the Indus Health Network where I work. A national steering committee was notified and a technical working group with members of both the PGSSC and my own team in Karachi were able to work together to further this agenda. Following this, we had a national stakeholders conference in Pakistan, and this conference allowed us to convene a group of about 50 people from across the country, an additional 20 people from various donors and stakeholders, together under one roof. The opening event was attended by over 150 people, whereas the two-day workshop had a smaller core group of about 60 or 70 people attending and contributing to developing a consensus statement. This really meant that a number of surgeons, orthopedic surgeons, representatives of the surgical and anesthesia societies, public, private sector, our credentialing colleges, the Pakistan Medical Council, the Nursing Council, were all represented at this meeting and managed to agree on a consensus statement on how to take forward the work of surgical planning in the country. So we made very sure that this was, while it was ministry-led, it was owned by the very stakeholders who will eventually be implementing this plan. The consensus statement was really a kind of a framework on which we were going to draft out a national surgical vision document, which I'll talk about shortly. It's important to understand that our national health vision, which was drafted in 2016, did not mention surgical care at all. They said, well, obviously it's a part of it, but it never said so throughout the document. And therefore, we felt the need to have an addendum document to the National Health Vision, which would highlight the importance of surgery and lay out a strategy in using which we would all be able to work together to optimize surgical care across the country. A draft document was formalized, and this document was then taken to all the provinces to get a wider buy-in with provincial stakeholders, because obviously the numbers at the national meeting were limited. We were able to go back and meet up to 30 to 50 participants in each province and get their feedback. And this really allowed us to create the National Vision for Surgical Care, committed to strengthening surgery, anesthesia, and obstetric services in Pakistan. And our partners remain PGSSC, WHO, led by the Ministry and Indus Health Network, where I am based. So this is a picture from the Islamabad meeting where Dr. Mehra was there, Dr. Sania Nishtar, who is now leading our Ministry for Social Development, was also present, Walt Johnson, WHO by the WR at that time, and our College of Physicians in Surgery were also represented at this meeting. And then, as I said, we went to each and every province to get this huge buy-in. This was a busy week in which we had representatives from the PGSSC and my own team join with provincial stakeholders in the 4 provincial capitals and get their buy-in. As a result of this, we prepared the National Vision for Surgical Care, and because of delays in the process due to COVID over the past year and a half, we were finally able to get ministry approval. The ministry was absolutely distracted with handling the pandemic, and things are holding out good at our end so far. But we were able to launch the National Vision for Surgical Care exactly 1 week ago, last Monday, with the support of UNITAR and other international and national partners. The vision of this document is that all Pakistanis have access to safe, timely, and affordable emergency and essential surgical, obstetric, and anesthesia services, so that they may live healthy and productive lives. This is really a extrapolation from our National Health Vision statement. This document provides a framework to optimize surgical care delivery, focusing on the 6 domains that Dr. Corlew has already talked about earlier today. It specifically highlighted province-wise challenges and actions that each province said they wanted to focus on. And then finally, we laid out a set of indicators and time-bound targets, and these targets were laid in conjunction with the ministry. And what are the metrics that are already being collected in the country as a starting point? So we understand that these metrics are iterative. These indicators and targets will evolve over time, and we will continue to change and improve these targets as we move forward. So finally, this is the official launch last week, and I'm very grateful to all the participants and the stakeholders who made this possible. At the very last minute, I decided to include a couple of slides on our surgical indicators baseline survey in Pakistan to today's talk. And the reason is that I believe that quantifying where we stand today is very important as we set our targets in our surgical plan. While they may not always be achieved, having that short-term and then a long-term horizon to look for in terms of actual numbers helps get everyone on the same page. So we realized that we had absolutely no national level baseline data, and we decided to, in 2019 and 2020, we went ahead and collected data from 2 different arms of surveillance. One was approaching 770 households across Pakistan, where about 5,400 household members were asked questions about how they access surgery, how many surgical procedures took place in those households in the past 3 years, and we reached certain conclusions, and I'll share that in the next slide. Secondly, we approached patients admitted for the 3 bellwethers, which is C-section, laparotomy, and open fracture reduction in 13 public sector hospitals across Pakistan. These are tertiary level hospitals where large volumes of these surgical procedures is being done. And we talked to patients who were admitted for one of these procedures or to their family members and asked them certain questions about how they had reached the tertiary care facility for the care that they needed. And also, what was the financial impact that these surgical procedures had on this on their lives? So these are the key findings that I wanted to share with all of you. Again, this survey was done over a 6-month period, but spread across 2 years because of COVID interruptions. And we interviewed 526 patients in these 13 hospitals. And in a separate arm, 770 households were accessed. And I'm going to give you just the 5 or 6 highlights of our data. We found there to be a huge urban and rural disparity in access and volumes of surgery. Now, what this really means is that in some urban areas like Karachi, we are reaching the SAO density target and the 2-hour access target. We're well within the targets that have been suggested or proposed by the Landsat Commission. However, when we look at rural target areas, we are well below the target. So what we're dealing with in a country like Pakistan, and I'm sure similar South Asian settings, is that within one country, we have the haves and have-nots. Within one country, we have a high-income reality and a low-income reality. The problem really is that we often look at this, because we sit in cities, we often look at these problems from the viewpoint of our urban settings. And I'll talk about that a little bit in my take-home messages. In the households that we talked about, only, in the hospital patients that we approached, only 58% had 2-hour access, and just under 50% came to these tertiary hospitals from outside the city. This means that our district hospitals that are secondary level hospitals and working closer to the homes of people are not optimally staffed and resourced. That is why people have to come from their homes, which are rural, peri-urban towns, all the way into urban centers to tertiary hospitals for the three surgical procedures that are essentially secondary level procedures. And this clearly illustrates the gap that we see. 51% of our population relied on hardship financing. That means they had to borrow money, sell assets, or rely on other methods of funding in order to come to the cities to get these surgical procedures done. 70 to 80% of our patients experienced impoverishing and catastrophic health expenditures. And the last bit, I was startled when I saw this data myself. I actually went back to double check. 56% of patients at the tertiary hospitals were poor. However, from those 44% that were not poor, did not meet the national or World Bank thresholds of poverty, 37% of those became newly poor. You know, as my friend, Dr. Nobajit Roy from India said, we now have a novo poor, not the novo rich. So we have newly impoverished people, about a third of them became newly impoverished. And it's important to remember that these people had not gone to expensive private sector hospitals. These interviews were conducted at public sector, free of cost hospitals, but they became impoverished because they had to travel, spend money to reach these hospitals. They had to pay for attendants or family members staying outside. Many hospitals are not able to provide all the materials or antibiotics or implants that are required for surgery, and those have to be purchased out of pocket in some situations. And finally, many of these patients have to buy food just to stay in a city for a week, and buy food for themselves or their relatives puts them below the poverty level. This is startling data and a reality that many of us are facing in our countries, but something that we all realize we need to do something about. So if I were to look at I'm going into the last bit of this. So we then talked about how are we going to implement this plan? And that really has been our challenge, and the challenge in many countries that have adopted the NSOAP framework. How do you translate a plan into implementation? Now, if I go back a little bit, we had originally planned to work through provincial PSOPs, provincial plans, which would be catered to each province or each region. And given the reality of our devolved health system, we thought that was the best way forward. However, in about 2018, while we were working on the national surgical plan, there was a pilot initiative known as the Universal Health Coverage Essential Packages for Health Services implementation in Pakistan. And we realized, I'm going to talk about that in a little bit, but we realized that that was probably the best way for us to nationally implement our surgical plan. So we had the Essential Package of Health Services. This initiative was taken by the DCP3 network initiative based in the University of Washington in Seattle, the London School of Hygiene and Tropical Medicine, Pakistan's Ministry of Health and its 5 provincial departments of health, the World Health Organization, and the USAID-funded Health Services Planning Unit. So during 2018 and 2019, this group has been meeting over the past 3 years in an iterative process where they looked at the burden of disease data in Pakistan, did a series of consultative workshops, which allowed them to prioritize and cost interventions. And our group worked in parallel to provide them with the costing templates for the surgical interventions and to decide which of the surgical interventions needed to be prioritized in this Essential Package of Health Services plan. And then finally, they are looking to develop implement this package in the Islamabad Capital Territory starting this month. So what we defined were 46 emergency and essential surgical procedures. We used the list provided by the DCP3 evidence as our starting point, but made adaptations and changes in this to meet our national needs. And if we look across care levels, the largest group need to be provided at the first level. Children-specific interventions were 4, and 42 of them are adult interventions. We added on addendums for 19 children-specific conditions. So I'm just going to give you an example to clarify my point. When we look at colostomy, which is part of the list of essential surgical procedures, in an adult, a colostomy is a very different procedure. But if you have a newborn baby with, let us say, a Hirschsprung's disease or an anorectal malformation requiring a colostomy urgently at 1 or 2 days of age, then the infrastructure and resource requirement is very, very different. A standard district hospital in Pakistan cannot cater to a 1 or 2 day old child. So we added addendums to accommodate for the specific needs of children. And this again ties in with what I said initially. When you have a very young population like Pakistan does, this is extremely important to incorporate into your national surgical plan. The way this is allocated in the cluster across the essential package is that it comes under 33 interventions come into the health cluster. 8 of them are in the maternal and child health cluster, including C-sections. And it's very important to realize that while we've talked about MNCH as a national priority, very few of us tend to recognize and remember that C-sections, which are a key cornerstone of MNCH services and safe deliveries, are essentially a surgical procedure requiring a surgical platform, surgical resources to be able to be provided. And extrapolating and using those same resources for other procedures is very doable, because if you're able to provide C-sections at first level hospitals, you already have the infrastructure to provide the other 45 or so procedures that need to be provided there. Now, I put in the slide to show that the specialties that do these 46 surgical procedures that we talked about include everything, including general surgery for adults and children, OBGYN, orthopedics, pediatric surgery, ophthalmology, plastic surgery, neurosurgery, dentistry, acute care, and neurology. These constitute the 46 procedures. What this highlights is that if we are to deliver these 46 procedures at a secondary level hospital, are we then saying that we need to have all of these specialists sitting at a secondary level hospital? It's clearly not feasible. So what we're working on with our government and our credentialing body is to see how can we get these procedures to form the curriculum of a community surgeon, what they call the rural surgeons in India, or district surgeon or community surgeon. This nomenclature has been used variably. But what we need is a good old-fashioned general surgeon who can provide a horizontal platform of expertise that is able to deal with the bulk of these 27 procedures that need to be taken care of at the secondary level. In reality, what we see right now in Pakistan is we require an ortho. So first of all, how do you convince 4 or 5 different kinds of surgeons and anesthetists to work in a rural area? And if you find all of these people, how do you retain them? Because they really want to be posted back to the cities as soon as possible. Once you manage to retain some of them, they want to know, okay, I've done with fracture fixation. I want equipment to do a arthroplasty because I'm trained as an orthopedic surgeon. So career-wise, it's very frustrating for them not to be able to follow a vertical pathway. And for the system, it's very frustrating because you need to hire, retain all of these surgeons to do multiple procedures. So the solution really is for our countries like Pakistan to invest and rethink in an age of specialization, to think about how can we create a general surgeon who can address most of these issues at a secondary level hospital. So my last two slides, I'm going to be talking about our learning experience, and they link in with many of the points I've made before. So I'll try not to repeat myself. One of the points that I think about is a lot is NSOAPs are essentially another vertical program. And in an age of universal health coverage, we need to be very, very cautious that we are not pitching this as a vertical program that is going to create yet another silo. So the importance of ministry ownership, government ownership, and integration within the UHC package is very important. It's important to note that the NSOAP, as previous speakers have said, is a very adaptable framework. But as we adapt it and implement it, we must take care that we don't create yet another vertical silo, but recognize that surgery is cross-cutting in nature, and it has the power to actually strengthen a health platform and allow this to be part of a base on which multiple interventions that are part of a universal health coverage package can be implemented. And that's exactly the kind of journey we are on in Pakistan with integration of surgery into the EPHS framework. Provincial regional autonomies are important because some parts of Pakistan have different realities from others. And I'm sure that is the case in Nepal as well. There are geographically remote areas that need to be catered to very differently from urban areas, and that has to be kept in mind. Population dynamics, I've already talked about larger populations. We've had, I look with disbelief and envy, I must say, at national surgical interventions in some African countries where they're talking about a total of 12 facilities and 30 odd surgeons. And we're talking about 12 medical colleges in Karachi alone. So the number of people that we need to involve as stakeholders and as end users is huge. And that makes our challenge just a little more difficult. The urban-rural disparity we've already talked about. And then, as I said before, the rich-poor disparity within the country. Urban Karachi will have surgeons and anesthetists and specialists that are second to none anywhere in the world. And yet our rural poor continue to suffer. The problem inherent is this, that those of us who attend meetings like today's, those of us who attend the meetings in Islamabad and design the national surgical plans come from these very urban settings. And therefore, many of us actually refuse to think there's a problem in the rural areas. We say, well, there's a glut of surgeons in Karachi. But that is what is missing. There are less voices from the true community or the district surgeons at these forums. And it's important to hear those voices as we develop our national surgical plans. The contrast then is we are looking at people here in Karachi and in Lahore and in Islamabad who want to buy surgical robots in an age where we're still dealing with TB perforations. This dichotomy continues to be seen at various levels. And then this local versus imported leadership. I believe that Pakistan's national surgical plan got where it was because of our international partners and support. It wouldn't have been possible. We needed that top-down push, which I think Nepal is getting through the Global Surgery Foundation and PGSSC today. This is exactly the situation where we were about 3 years ago. However, it is very important to recognize that leadership must also be local, to be responsive and respectful of national, provincial, district realities. And again, we have these, as I said, these centers of excellence that tend to dominate the leadership forums, and it's important for these centers of excellence to be sensitive of the rural needs. The role of private sector is something that is often overlooked in South Asia. It's a huge player across this area. 70% of all healthcare in Pakistan today is provided through the private sector. And therefore, it is very important that even as we involve the ministry stakeholders and the health ministry takes a leadership role, that they do not sideline the private sector. This is the reality of Pakistan, at least, and I know most of our neighboring countries, and therefore involving the private sector and strongly regulating the private sector is very important. And then obviously, as Dr. Park has talked about, the financing of surgical care remains the biggest hurdle. How do you ensure that it gets the funds it requires? How do you ensure that the government ministries do not allow the purchase of high-end equipment for urban centers of excellence on public money, on taxpayer money, even while the rural areas don't have a single surgeon or even the basic needs of a surgical OR. So these really were my points and my experiences. And our challenge remains. This is the reality of a lot of rural Pakistan. One of our health workers is sitting in the middle of a family in the Thar area of Sindh. And we need to make the photograph on my right available to them to ensure that surgery is efficient, is scientific, and is safe for all these people when they need it, where they need it. This is my email address. If any of you have any questions or want to take up conversations after this event, I'd be happy to have a chat. Thank you so much.
Thank you, Dr. Lumna Samad, for a very nice and informative presentation. Dr. Samadको प्रेजेन्टेसन सकेसँगै हामी कार्यक्रमको करिब अन्तिमतिर पुग्न लागेका छौँ। अब म यस कार्यक्रमका प्रमुख अतिथि स्वास्थ्य सेवा विभागका महानिर्देशक डाक्टर दिपेन्द्र रमण सिंहज्यूलाई आफ्नो छोटो रिमार्क्स राखिदिनु हुनको लागि हार्दिक अनुरोध गर्दछु।
Thank you very much. First of all, I would like to thank the organizer. I can see the global, in global level, the surgery and the surgical perspectives and how the universal health coverage has seen surgery in days to come. Thank you very much, all the dignitaries, the chairperson, and all the dignitaries on the dais, and who have here connected by virtually. I would like to thank all of you on behalf of Ministry of Health and Population. There is a very special kind of things going ahead, and for your kind information, the coincidence is the system, the health system just got a new health secretary. My friend Dr. Rosen has just been, deputed as secretary, health secretary. So it's just a coincidence, and we can see, the enabling environment is going on. And just to name few of other enabling situations and enabling factors which we have already come up with are the Public Health Act, which has envisioned a community. I can see all the presentations has shown that there are certain kind of things we have already done, and certain things we have to do in days to come. And at the same time, as I'm telling you guys, the enabling environments like the Public Health Act envision one committee which can also look upon all these possible needed policies and all. And so far, while the policies related to the surgical, obstetric and anesthetical services are concerned, and the universal health care is also there. So three things is very important. The first one is the coverage itself, how far we have gone till date and how we can go ahead. That is very important one. And the second thing is, can we maintain the quality as expected? It is very important. And at the same time, as you all know, the cost, whether the cost is really reliable or not. These three things actually, define the, how best we are going with the universal health coverage. And we all know this is the SDG era. And the SDG era, as we have been, already discussed and been, talk about, that the principles behind it are, the first and foremost thing is the universality itself. No one should live behind. And while we are making policies, we should keep it in our mind. And thank you all who have presented today, beautiful and very well structured one, really, very envisioned one, and the work they have done is really, definitely guiding us. And I can also see the possibilities, even at the Miyagar resources. So that is another important part we have learned today. And thank you very much for orienting all of us. My team, I can see the new generation who are there to, look after the whole system for the days to come. They have been oriented well with this, program. And at the same time, I can see my teachers who have been in this field for so many years, and they know, the villages where even, the people, they really have tough time to have 2 times meal. And at the same time, they have to walk hours to reach to get the basic health services. And at the same time, there are a lot of other great changes going on. So we have to, consider all these developments, and we have to come up with the, the right policy which will actually address bits and pieces of what we have in our context. And thank you very much, all the global leaders who have been coming up with all the possible solutions. We will definitely take your suggestions, and we will definitely walk the road you have shown. And for that, we have our local leaders, people who will guide us. And we have already made the platforms which will definitely, give us some impetus to go ahead. And for your kind information, the COVID-19 era has also given us some kind of, I would say, a kind of, impetus, or I would say some kind of, resilience, so that, we can see even, greater, future of this medical field. So everyone is sensitized now. Everyone knows, without the infrastructures, without the trained human resource, without the governance, without the financial security, and at the same time, without the informations, it will be very difficult to go ahead. And while we are envisioning the right policy, we should take care of all these things, as rightly pointed out by almost everyone who have presented today. And please accept my apology. I was a bit late because I was with the COVID part as well. Today we have initiated the Johnson vaccine, and today almost more than 30,000-40,000 they have been vaccinated with this newer vaccine. And thank you, US government. Today morning, Right Honorable Prime Minister visited all the most of the vaccination site, and instructed and gave direction just to go it with in easier way, so that people won't have any problem. So all these words, I would like to congratulate the whole team, the national and global team, just to come up with this very, very important perspective, which has been really, neglected in some sense. We have to incorporate it in different perspective of public health interventions. As we know, there are different kind of prevention. The primordial prevention, the primary prevention, the secondary, tertiary, and quaternary preventions. In all these kind of things, these surgical perspectives will be there. We have to fit it in all this kind of our endeavor. So let's see, together we will be able to have better policies in days to come. We have already done a lot of things, and we will definitely do the rest collectively, unitedly. Thank you very much.
धन्यवाद डाक्टर साहब। हामी कार्यक्रमको अन्तिम चरणमा आइसकेका छौँ र सम्पूर्ण सहभागीलाई भोट अफ थ्याङ्क्स दिँदै कार्यक्रमको समापन गरिदिनु हुन म यस कार्यक्रमका अध्यक्ष तथा गुणस्तर मापन तथा नियमन महाशाखा प्रमुख डाक्टर मदन कुमार उपाध्यायज्यूलाई यहाँ आमन्त्रित गर्दै बिदा हुन्छु। डाक्टर सर।
Yes, thank you. Thank you very much. Respected Chief Guest, Director General of Department of Health Services, dignitaries and dais, delegates virtually connected from different part of the world, virtually connected of different part of Nepal, guests and delegates connected with us in person in this hall. I want to express my gratitude and huge thanks to you all for your active participation. You all made our day. So I am in the last moment of this event. I just want to brief about our sessions which are going to be conducted tomorrow and day after tomorrow. We are going to have 2 breakout sessions tomorrow with government officials from Ministry of Health, Department of Health Services and Provincial Government, and another breakout sessions with ETPs and donors. And we will have another breakout session on 21st July, which will be with academia and professional societies. So I request all my friends, fellow colleagues to be present in person who are here from Ministry of Health, Department of Health Services tomorrow at sharp 4:45 p.m. in this hall. Last but not the least, I want to express my thanks to our keynote speakers, Dr. Jeff, who is Senior Health Advisor from UNITAR and Executive Lead of Global Surgery Foundation, our WR to Nepal, Dr. Rajesh Pandav, Chairman, Nepal Medical Council, Dr. Bhagwan Koirala, Director General from Department Ayurveda and Alternate Medicine, Director General of Department of Drugs, and our speakers, Dr. Scott, who is a lecturer in Harvard PGSSC. He had a very wonderful presentation. And Dr. Key Park, who is the Director Policy and Advocacy, Harvard PGSSC, who showed what NSOAP is and what NSOAP is not. And very huge thanks to Dr. Lubna Samad, Director IRD Global Pakistan, who had just launched NSOAP as per their need in Pakistan last week. And she showed lots of similarities in Asian countries, which we can also follow, and she showed a way forward for Nepal to implement NSOAP. So I take an opportunity to thank the representatives from Ministry of Finance who are connected virtually, Planning Commission, representative, chief and directors of divisions and departments of our MoHP and DOHS, section chiefs of MoHP and DOHS, secretary from Provincial Ministry of Health and Population, representative from academia, professional societies, EDPs, and the NSI team, without whom we could not have this event organized. So I express my thanks to all who are in this room, and I am very much thankful to the moderators who are present in person here, who are going to moderate 4 breakout sessions tomorrow and day after tomorrow. So I thank you all to be present in person here and connected virtually with us. Thank you all and have a good night. Thank you.